Assalamu alaikum. We started our lecture today is anemia in pregnancy. The student must know the definition of iron deficiency anemia and must know the causes of iron deficiency anemia, must know the clinical features of iron deficiency anemia, must know the diagnosis of iron deficiency anemia, and must know the treatment of iron deficiency anemia, and must know the types of other types of anemia in pregnancy. And nice to know the details about the other types of anemia in pregnancy. Anemia is one of the most common disorders affecting humans in the world. The WHO defines the anemia as hemoglobin levels less than 11 grams per deciliter. Chronic anemia results in the sense of well-being, fatigue, stress, decrease in work capacity. Anemia in pregnancy is associated with increased risk of maternal and fetal morbidity and mortality. We must classify the anemia according to its severity into mild, moderate, severe, and very severe. In mild, hemoglobin level 10 to 10.9, moderate hemoglobin level 7 to 9.9, severe hemoglobin level is less than 7, very severe hemoglobin level is less than 4. Physiological changes in pregnancy. Healthy pregnancy and puerperium are associated with marked physiological changes in the circulating blood, increase in blood volume, and alteration in factors involved in hemostasis. These changes have relevance to the most potential and hazardous hematological problem of pregnancy and delivery. These are: number 1, increased demand; number 2, controlling big problem facing the mother after delivery, which is the postpartum. Physiological changes in pregnancy: when the blood volume regarding plasma volume and red blood mass are increased. This means a hypervolemic state modified the response to hypotension in the first half of pregnancy and the blood loss at delivery. The amount of blood loss during vaginal delivery about 500 cc. When it is more, it means that the patient developed postpartum hemorrhage. During cesarean section is around 2 pints, 1000 ml. When it is more, the patient considers to develop postpartum hemorrhage. Hemoglobin level with iron deficiency anemia will be decreased. In addition to the decrease in MCV, the MCH, and the MCHC, all the hematocrit will be decreased. All can be calculated from the RBCs, hemoglobin, packed cell volume, and these tests give basic guide to the diagnosis of anemia in pregnancy. The cause of anemia in general, it means either the intake is less than normal, or absorption is not good, or excretion is more, or demand is more than the intake. When it is associated with nutritional, it will lead to iron deficiency anemia. Pre-pregnancy poor nutrition very important. When the patient enters to the pregnancy with anemia, she will develop 100% anemia during pregnancy. Bedside iron, folate, and B12 deficiency also important. Chronic blood loss due to parasitic infection, hookworm, malaria, multiparity, multiple pregnancy, acute blood loss in antepartum hemorrhage or postpartum hemorrhage, recurrent infections, UTI, anemia due to impaired erythropoiesis, hemolytic anemia in pregnancy, like in PIH, pregnancy-induced hypertension, like HELLP syndrome, hemoglobinopathies like thalassemia, sickle cell anemia, in addition to the aplastic anemia, which is rare in pregnancy. MCV is the most sensitive indicator of underlying iron deficiency. This will be decreased. Hypochromia and MCHC appear with more severe degree of iron deficiency anemia will be decreased also. Serum ferritin level will be decreased. Total iron binding capacity increased. Total serum iron decreased during pregnancy with iron deficiency anemia. The pharmacokinetics of iron with daily requirements during pregnancy. Normal diet containing about 14 milligram of iron. Absorption of iron is 5 to 10%. This means 1 to 2 milligram and 3 to 4% in a pure vegetarian diet. Additional daily iron demands in early pregnancy 2 to 3 milligram per day. In late pregnancy it's 6 to 7 milligram per day, so daily supplement of 40 to 60 milligram of elemental iron is required during pregnancy. Folic acid requirement is also increased into 500 to 600 microgram per day. In strict vegetarian people, vitamin B12 is also deficient. What is the clinical presentation? It depends on the severity of the anemia, and when severity of anemia, it depends on the women at risk, like adolescent, multiparity, multiple pregnancy, low socioeconomic status. When the anemia is mild, the patient come with asymptomatic features. When she has moderate to severe anemia, the symptoms will occur in addition to the signs. These symptoms are pallor, weakness, fatigability, dyspnea, palpitation, swelling over a feet and body. Signs related to pallor, facial puffiness, raised JVP when associated with heart failure, tachycardia and tachypnea, crypts in the lung bases, hepatosplenomegaly, pitting edema over abdominal wall and legs, and associated with hemic murmur, cardiac failure, glossitis, stomatitis, chillosis, and brittle hair. Investigations. Severity of anemia depends on the hemoglobin level, hematocrit. At the first visit, we must do it, a CBC, at the 28 to 30 weeks, and 30 weeks also we must do it. طبعا types of anemia we depend on the blood film in order to know the types of anemia, whether it is microcytic associated mostly with iron deficiency, macrocytic associated with B12 and folate deficiency. Normocytic may be related to acute blood loss. Hemolytic or pancytopenia may be related to bone marrow failure, or may be related to HELLP syndrome like in preeclampsia. Bone marrow activity will be increased in hemolytic anemia. That's why retics count will be more than 2 to 2.2%. High bone marrow activity is seen in hemolytic anemia following acute blood loss, iron deficiency anemia on treatment, and cause of anemia we must know by various investigation in order to know the type or the cause of anemia and try to correct it. Management, we must confirm the diagnosis depend on the history, clinical examination and investigations, and treatment depend on degree of anemia and the gestational age. What is the effects of anemia on pregnancy and mother? There is higher incidence of pregnancy complications like preeclampsia, abruption, preterm labor, predisposed to infection like UTI, pulmonary sepsis, increased risk of postpartum hemorrhage, subinvolution, lactational failure, maternal mortality due to congestive heart failure, cerebral anoxia, sepsis, and thromboembolism. Effect of anemia on fetus and neonates: higher incidence of abortion, preterm birth, IUGR, IUD, low Apgar at birth, neonates more susceptible for anemia, infections, higher perinatal morbidity and mortality, anemic infant with cognitive and affective dysfunctions. Most critical point is 28 to 30 weeks of gestation because of increased demand, in labor because there is postpartum risk of postpartum hemorrhage, immediately after delivery because of lactation, where early puerperium also because of lactation and other demands. Congestive heart failure also it is most critical because this means the patient is in critical periods. This means the failure of the heart to cope up with pregnancy-induced cardiac load because of severe anemia. The treatment, either nutritional or supplement either oral iron or injectable either IV or IM, والبلاد transfusion. Iron therapy, there's a various form depend on the compliance, associated symptoms, GIT symptoms, availability of the medication and the cost. These 4 important points in order to give iron supplement during pregnancy. Oral, we have 2 forms of oral iron, ferrous fumarate and ferrous sulfate. It does depend on the level of hemoglobin. Supplement folic acid may be needed, especially بالearly pregnancy, بالearly and late pregnancy. بالearly pregnancy, we can give only folic acid because the demand is less. We need to give folic with ferrous in the progressive of pregnancy to the end. And give proper instructions because the instructions is important in order to increase the iron absorption through the GIT. طبعا injectable قلنا عندنا 2 forms, عندنا الانتراماسكولار وعندنا الانتراvenous infusion. The following statement about the oral iron prophylactic during pregnancy are correct. Gastric side effects are dose related. Iron absorption during the first trimester of pregnancy is decreased compared with non-pregnant state. That's why احنا بالايرلي pregnancy دائما نعطي الفوليك اسيد لان هو اصلا absorption قليل فما ما نستفاد من عنده اذا انطيناه. Non-compliance of the mother occur in less than 10%. Oral maternal iron prophylaxis is recognized to be associated with increased MCV level. Iron deficiency anemia in pregnancy, MCHC and the MCV are low. Blood transfusion is indicated if the hemoglobin is less than 9 gram per deciliter and there is an increased risk of preeclampsia and there is no proven danger of teratogenicity from iron therapy. What are the indications of blood transfusion when the anemia is severe? First seen after 36 weeks of the pregnancy. Anemia due to acute blood loss like APH and postpartum hemorrhage. Associated infection, patient not responding to oral or parenteral therapy. Anemia and symptomatic pregnant women like dyspnea with heart failure, extra, irrespective to age. Management of labor. How can we manage patient with anemia during labor? Labor should be supervised, proper counseling and consent to be taken, blood whole or packed, kept cross-matched, women nursed in a proper up position, intermittent oxygen to be given, precaution to prevent infection and blood loss, strict aseptic precaution and minimal PV examinations, prophylactic antibiotic can be given, patent IV line, but the fluid are avoided, in decompensated patient diuretics should be given. Postnatal care and contraception, early ambulation is encouraged, hematinic are continued for 3 to 6 months, watch for subinvolution, purpural sepsis, congestive heart failure, thromboembolism and lactation failure, avoid pregnancy at least for 2 years, barrier contraception, progesterone only pills after 3 weeks, intrauterine contraceptive device or permanent sterilization should be done. We have a clinical scenario, 25 years old, gravida 2 with a normal past obstetrical history is found to have a hemoglobin level of 10 gram per deciliter at 32 weeks of gestation. The hemoglobin at booking 12 weeks was 12 gram per deciliter and she has not taken iron supplements during this pregnancy. Full investigations show a mean corpuscular volume of 32 and MCV level of 86 femtoliter. The blood film shows some polychromasia and microcytosis. These findings are diagnostic of iron deficiency anemia. MCV is a better guide to presence of iron deficiency anemia than the hemoglobin level. Should iron deficiency occur later in pregnancy, parenteral iron will raise the hemoglobin level faster than the oral iron. The other form of hemoglobinopathies, we have sickle cell disease is the same given to group is the name given for group of inherited blood conditions which include sickle cell anemia, sickle cell beta thalassemia, hemoglobin SC disease, and the most common and severe is sickle cell anemia. What causes sickle cell anemia? Inherited disorder of hemoglobin structure. Antenatal care, sickle cell trait, when the hemoglobin SA found may have UTI and microscopic hematuria, sickle cell anemia, bad obstetrical history, painful crisis, jaundice, anemia, deformed pelvis, increased rate of operative deliveries like cesarean section, and avascular necrosis of the hip. Diagnosis will depend on hemoglobin electrophoresis. It is not specific for hemoglobin D and G. Sickling test not specific for hemoglobin C and hemoglobin Memphis and hemoglobin M. Hemoglobin solubility test is specific, cheap and rapid and simple with retics count and hemolytic anemia. Combinations HBSS and pregnancy hazards. طبعا increase the risk of infection because of risk of anemia, risk of heart failure increase, painful crisis will lead to increase complications, risk of embolism and stroke is high, pulmonary hypertension, dysfunction, retinal disease, leg ulcer and cholelithiasis. How can we follow the patient antenatally? Mother must send to midstream urine to exclude an infection, blood pressure, specific urine for the protein, renal function test, liver, complete blood. Will they have iron deficiency anemia? Will they have iron deficiency anemia? No, because of hemolysis, the iron will be deposited and the serum ferritin level will be high in hemolytic anemia. How can we monitor the fetus? طبعا by ultrasound to assess its viability below the 9 weeks, to assess the abnormality in the first trimester 11 to 14 weeks, and to detect other congenital anomaly after 3 weeks with anomaly scan, or biometry for the fetal growth in order to assess whether it developed IUGR or not every 4 weeks for fetal growth. We give folate because they have folate deficiency. We give aspirin to prevent hypertension and decrease the risk of thromboembolism. We give heparin when she has previous history of thromboembolism. We give it as a prophylactic form. In the pregnancy, we must avoid hypoxia, acidosis, infection, dehydration, stress, exercise, and extreme temperature because all of these may lead to more hemolysis. The treatment, it is a multidisciplinary approach. Supportive measures is important, rehydration, analgesia, blood transfusion in order to keep the hemoglobin as less than 40 and hemoglobin A, which is a functional hemoglobin, less than 60%. Maternal sickle cell disease, the spontaneous miscarriage is increased, the incidence of proteinuric hypertension increased, the incidence of spontaneous delivery is increased, spontaneous preterm delivery, the incidence of small for gestational age is unchanged. The presence of sickle cell disease in the fetus cannot be diagnosed clinically. We must diagnose by fetal medicine like amniocentesis and others. Thank you very much. We will shift to other lecture, which is renal disease and pregnancy. Renal disease and pregnancy. The objectives of this lecture. The student must know the definition, must know the causes, must know the diagnosis, and nice to know the other renal disease and pregnancy. Important points: UTI lead to maternal morbidity and perinatal morbidity via prematurity. Renal disease like preeclampsia and IUGR, hypertension plus proteinuria in the first or early second trimester suggests a pre-existing renal disease. Serum creatinine is mandatory to exclude pre-existing renal disease. What are the physiological changes in pregnancy related to renal system? Ureters and renal calyces dilatation remembered in the ultrasound. When do an ultrasound, the result coming with there is a dilatation of the ureters and both renal calyces because of pressure of gravid uterus. The plasma volume will be increased and the plasma flow with the glomerular filtration rate also increase, lead to increased urinary protein excretion and increased creatinine clearance. That's why the upper limit of serum creatinine clearance falls to 65 millimole per liter. The upper limit for proteinuria throughout pregnancy is 300 milligram per 24 hours. Now we will discuss the urinary tract infection, UTI, which is a most common problem during pregnancy and not pregnant women and in non-pregnant women. The incidence is more common in pregnancy due to physiological dilatation of the upper renal tract. That's why it's common in pregnancy. Asymptomatic bacteria account for 4 to 7%. Around 40% of them will develop symptomatic. Then we must do a general urine exam as a routine test during pregnancy in order to know this percent, which is 4 to 7%, اللي هي 40% ممكن تتحول إلى symptomatic UTI. In addition to the cystitis, 1% of pregnancies, pyelonephritis, 1 to 2% of pregnancies. Predisposing factor. Previous history of UTI is important. Diabetes mellitus like polycystic kidney, urinary tract calculi, renal tract abnormality like duplex kidney or ureter, neuropathic bladder, spina bifida, multiple sclerosis, drugs, steroid or immunosuppressant drug. Presentation: either asymptomatic like asymptomatic bacteriuria in patient with predisposing factor like midstream urine specimen as an antenatal screening. يعني any patient at a predisposing factor نتوقع ممكن يكون عندهم asymptomatic bacteria. That's why لازم نسوي midstream urine as a part of antenatal screening. Clinical feature includes cystitis, urinary frequency, dysuria, hematuria, proteinuria, and suprapubic pain. In pyelonephritis, there is a fever with loin pain and or abdominal pain with vomiting and rigor. Diagnosis, dipstick urine for protein, midstream urine analysis infection. When there is a bacteriuria around 100,000 organisms per ml of urine or more, it's considered to be infection. Midstream urine for culture and sensitivity, it should be repeated if it is non-significant or with mixed growth. Asymptomatic bacteria, a 3 days course of antibiotic oral to prevent pyelonephritis plus preterm labor. Acute cystitis, we giving 7 days course of antibiotic oral. Urine culture following treatment to ensure eradication of organism. Recurrent bacteria occur in 15% of women in pregnancy and required a second course of antibiotic. ممكن يساعدنا recurrence. Ultrasound in patient with 2 or more UTI positive culture. ليش؟ حتى نشوف ال predisposing factors. Management of pyelonephritis, antibiotics we given 10 to 14 as an IV antibiotics for patient with vomiting or pyrexia. IV fluid may be required. Renal function test should be checked. Ultrasound to check hydronephrosis, renal calculi, and congenital abnormalities as a risk factors. Prophylactic antibiotics, 2 or more UTI, positive culture, that's say recurrent UTI, or more, or one of the above risk factors. These are the treatment regimes for the UTI in pregnancy. This is the oral antibiotic, this is the IV, and this is the prophylactic antibiotics. We will shift to other type or other part of renal disease in pregnancy, which is a renal impairment. The etiology may be due to reflux nephropathy, may be due to diabetes, may be due to systemic lupus erythematosus, may be due to glomerulonephritis, and may be due to polycystic kidney disease. We classified them into mild, moderate, severe, depending on the serum creatinine level. But the serum creatinine level also depends on the muscle mass. Figure representing moderate impairment in 85 kg male represents severe impairment for 50 kg women. The presentation, they are present with hypertension, proteinuria plus minus hematuria in early pregnancy. Blood tests for urea and creatinine must be done in such patients. What is the effect of pregnancy or renal impairments? Mild impairment when the creatinine level is less than 125 millimole per liter tolerate pregnancy well with no renal function deterioration. Severe renal impairment when the creatinine level more than 250 millimole per liter, there at an increased risk of permanent loss of function during and after pregnancy, and even end-stage renal failure may occur because of severe renal impairment. What is the effect of renal impairment on pregnancy? There is an increased risk of preeclampsia, IUGR, spontaneous and iatrogenic premature delivery. Severe renal impairment plus hypertension have less than 50% chance of successful pregnancy because of severe early onset preeclampsia with severe IUGR. Then there is no successful pregnancy at all. Premature delivery is justified in rapidly worsening renal function to avoid dialysis even in the absence of preeclampsia. Severe renal impairment lead to polyhydramnios and risk of cord prolapse due to fetal polyuria in response to high osmotic load from increased maternal urea. Number 3, nephrotic syndrome and heavy protein urea lead to severe hypoalbuminemia with associated risk of pulmonary edema and thrombosis. Management of renal impairment. Pre-pregnancy counseling and multidisciplinary care, documenting baseline value, pre-pregnancy and early pregnancy for the creatinine, uric acid, albumin and protein, tight control of even mild hypertension with antihypertensive agents. The choice is no different in women with renal disease. Discontinue angiotensin converting enzyme inhibitors prior to pregnancy or once pregnancy is confirmed. Discontinue diuretics unless there is severe hypoalbuminemia and incipient pulmonary edema. Admission in worsening hypertension, increasing creatinine, and large increase in proteinuria because of high risk of preeclampsia with difficult diagnosis in the presence of high blood pressure and proteinuria. Diagnosis of preeclampsia is supported by IUGI, thrombocytopenia, and abnormal liver function test. Prophylactic low dose 75 mg per day aspirin to decrease the risk of preeclampsia. Serial scans for fetal growth and liquor amount. Serial hematology and biochemistry. If renal impairment discovered in a pregnancy, not attribute directly to preeclampsia but do blood glucose for diabetes, renal tract, ultrasound, for example polycystic or small kidney suggesting chronic renal failure, and antinuclear antibody for SLA. Postpartum, we continue close monitoring. Angiotensin converting enzyme inhibitor are safely used to in breastfeeding. Another form of renal disease in pregnancy, we have a renal transplant. Pregnancy outcome in well-functioning renal transplant is similar to the general population. There is no difference. Pregnancy should be delayed for at least 1 to 2 years to allow graft function to stabilize and immunosuppression to reach maintenance levels. Risk in pregnancy is related to pre-pregnancy renal function and to the presence of hypertension. Women are immunosuppressed and prone to infection. Immunosuppressive drugs used in pregnancy like prednisolone, azathioprine, cyclosporine, and tacrolimus. Women using cyclosporine and tacrolimus are advised not to breastfeed because it affects the fetus or baby. Dialysis. What is the role of dialysis with pregnancy? Pregnancy on dialysis is unusual. Pregnancy on dialysis is unusual because end-stage renal failure reduced fertility. Patient on dialysis should be advised not to get pregnant. Common risk: anemia and hemorrhage. Increase the risk of miscarriage, fetal death, preeclampsia, preterm labor, polyhydramnios, placental abruption. Pregnant women required increasing dialysis to maintain the pre-dialysis urea less than 15 to 20 millimole per liter. Poor obstetric outcome is similar with both hemodialysis and peritoneal dialysis. What is the dialysis and pregnancy? There is an improvement in the survival compared to all reports because of more intense dialysis with blood urea nitrogen below 17 millimole per liter, 50 milligram per deciliter, almost daily dialysis. Higher dose of erythropoietin is required to provide adequate red cell mass. Metabolic acidosis and hypocalcemia should be corrected. Careful uterine and fetal monitoring during dialysis and throughout the whole pregnancy. Avoid hypotension during dialysis since this may provoke uterine contraction and fetal loss. Nutritional status and dry weight should be assessed on a frequent basis since intradialytic weight gain can be confused with the usual weight gain in pre-pregnancy. In spite of optimal therapy, mothers are at increased risk of severe hypertension and premature delivery with a mean gestational age of 30 weeks. If the patient is good, potential candidate for transplant, it's better to delay pregnancy till she is transplanted. Case presentation: 24 years old Sudan lady found to have raised creatinine when she was evaluated for primary infertility and diagnosed as end-stage renal disease was made. Her renal function continued to deteriorate and she was put on regular hemodialysis. A cadaveric transplant was done. The transplant was successful and her serum creatinine was around 1.2 mg per deciliter and she was maintained on azathioprine, steroid and cyclosporine. She became pregnant 18 months post-transplant with a full-term twin. Serum creatinine post-delivery was 1.3 mg. 1 year later, her serum creatinine was 1.4 and she became pregnant again. Hemoglobin before gestation was 9.4 gram. Hemoglobin decreased to 7.8 gram with more symptoms. Erythropoietin was added and her anemia improved with hemoglobin level of 11 at the time of delivery and the outcome of pregnancy was success. What about the renal trans with the pregnancy? Fertility retained after transplant with a pregnancy success rate of more than 90% after the first trimester. And there is a slight increase in spontaneous abortion and intrauterine growth retardation. Pregnancy has no important early effect on renal function and affected by the same factors in the pregnancy in patients with renal impairment. Women are advised to wait 1 year after living-related transplant and 2 years post-cadaveric transplant to avoid complications arising from rejection. Neither low-dose prednisolone or azithromycin appear to have adverse effect on fetus. The obstetrician should review the operative notes to confirm the location of the graft. Obstetrical management: increase the frequency of prenatal visits, early treatment of asymptomatic bacteria, monthly renal function, close monitoring for developing of preeclampsia. We have another form of renal disease in pregnancy, which is the acute renal failure. It is rare in pregnancy. Commonest causes: preeclampsia, hemorrhage, infections, drug, diclofenac, anti-inflammatory, and obstruction due to ureteric damage or stones. Most commonly complicates early postpartum period, characterized by oliguria, rising urea and creatinine, metabolic acidosis, and hyperkalemia. In the obstetrics, they may be associated coagulopathies. A rise in urea without concomitant rise in creatinine is observed following antenatal corticosteroid administration. Hemolytic uremic syndrome, rare cause, occur postpartum, associated with renal failure and thrombocytopenia, characterized by microangiopathic hemolytic anemia, diagnosed on blood film. And thank you very much. We will shift to other lecture, which is the thyroid disease in pregnancy. And we must know the objectives. The student must know the types of thyroid disease in pregnancy, must know the causes of thyroid in pregnancy. The student must know the clinical features of thyroid disease in pregnancy, and nice to know the treatment of thyroid disease in pregnancy. What are the physiological changes in thyroid function during pregnancy? Thyroid binding globulin TBG increase due to reduced hepatic clearance and estrogenic stimulation of TBG synthesis. The test result that the chances in pregnancy are influenced by the chances in TBG concentration. Plasma iodine level decrease due to fetal iodine use and increase in maternal clearance. Lead to notable increase in gland size in 15% of women without abnormal thyroid function test in order to concentrate the iodine. This is the physiological changes in thyroid function during pregnancy. This is the pregnancy and hyperthyroidism and hypothyroidism. The fetal thyroid begin to concentrate the iodine at 10 to 12 weeks and controlled by pituitary TSH by approximately 20 weeks. That's why we need to have an euthyroid during this stage, 10 to 12 weeks, because after that the pituitary gland of the fetus will take the job. Hyperthyroidism occur in 0.2% of pregnancies. Mostly Graves' disease accounts for 95% of cases. This is an autoimmune. طبعا الفيتشر مالت الهايبوثايرودism we know it انه increase in nervousness, tremor, tachycardia, frequent stools, sweating, heat intolerance, weight loss, goiter, insomnia, palpitation, hypertension, lid lag and lid retraction with pretibial edema or myxedema. What is the fetal and neonatal effect of hyperthyroidism? There's an associated hyperthyroidism with preterm delivery, low birth weight, and fetal loss. Fetal thyroid toxicosis are related to disease itself or treatment may affect the fetus. Risk of immune-mediated hypo or hyperthyroidism due to antibody crossing the placenta, especially in Graves or chronic autoimmune thyroiditis. Antibodies in Graves' disease can be either stimulatory or inhibitory. يعني اما تسوي hyper or hypothyroidism للفيتس. In units of women with Graves who have been surgically or radioactively treated are at high risk because not taking suppression. What are the causes and diagnosis of hyperthyroidism? طبعا قلنا الكوزز قلنا mostly هو autoimmune. الدايجنوس نشوف ال T3 ال T4 elevated, ال FTI also elevated, there is decreased TSH level in absence of goiter or mass, and most patients نلقى الانتيبوديز عالية لل TSH receptors, anti-microsomal or anti-thyroid peroxidase antibodies found, but measurement of these is not required, though some endocrinologists recommended measuring TSI, which are stimulatory antibodies to TSH receptors. Other causes may be due to excess TSH production from the gestational trophoblastic disease أو hyperfunctioning thyroid adenoma أو toxic goiter أو subacute thyroiditis or may be due to extrathyroidal source of the thyroid hormone. What is the aim of treatment? The goal is to maintain FT4 to FTI in high normal range using lowest possible dose, minimizing fetal exposure. Measuring FT4 to FTI in 2 to 4 يعني frequency matter 2 to 4 weeks and titrate. Thioamides and methimazole thioamide decrease thyroid hormone synthesis by blocking organification of iodine. Propylthiouracil also reduce T4, T3 and may work more quickly. PTU traditionally preferred. Older studies found that methimazole crossed placenta more readily and was associated with fetal aplasia or cutis. New studies refute this. لذلك الPTU أكثر يفضلون من الميثاميزول لأن هذا يأثر على البيبي. Treatment of hyperthyroidism. Effect of treatment on fetal thyroid function. Possible transient suppression of the thyroid function. Fetal goiter associated with graves, usually drug-induced fetal hypothyroidism. Fetal thyrotoxicosis due to maternal antibodies is rare. Screening for growth and normal fetal heart. Neonate at risk for thyroid dysfunction. Notified by pediatrician. Breastfeeding safe when taking PTU or methimazole. The treatment طبعا by beta blocker can be used for symptomatic relief إذا كانت severe tachycardia عند المريضة. Reserve thyroidectomy للwomen اللي هم unresponding to medical treatment. أو نعطيهم iodine 131. الiodine 131 is contraindicated because of risk of fetal thyroid ablation, especially if exposed after 10 weeks. You must avoid it. Pregnancy, breastfeeding for 4 months after radioactive ablation, also avoided. We will shift to other type of thyroidism in pregnancy, which is the hypothyroidism, which is the opposite. طبعا the symptoms with features and signs will be differ. Opposite: fatigue, constipation, cold intolerance, muscle cramps, hair loss, dry skin, slow reflexes, weight gain, intellectual slowness, voice change with insomnia. Can progress to myxedema and coma. Subclinical hypothyroidism, elevated TSH, normal FTI in asymptomatic patients. This is, we call it a subclinical hypothyroidism. May be associated with other autoimmune disorder like type 1 diabetes, 5 to 8% risk of hypothyroidism, 25% postpartum thyroid dysfunction. Hypothyroidism, fetal and neonatal effects with hypothyroidism. There is higher incidence of low birth weight due to medically indicated preterm delivery or preeclampsia or abruption. Iodine deficient hypothyroidism, congenital cretinism, growth failure, mental retardation, other neuropsychological deficits. What are the causes? May be autoimmune, may be due to subacute thyroiditis, may be due because of thyroidectomy, may be due to iodine deficiency. It is most common worldwide, but it is rare in US because they have a seafood rich with iodine. Treatment: we treated with thyroxine, levothyroxine in sufficient dose to retain TSH level to normal, adjustment the dose every 4 weeks, and check TSH level every trimester. The American College of Gynae and Obstetric recommended screening of all pregnant women with a personal history, physical examination, or symptoms of thyroid disorder. Question: 33 years old, gravida 3, para 2, at 10 weeks of gestational age, comes to office for her first prenatal visit. She reported that she had hypothyroidism in the distant past but was never treated and is asymptomatic. Physical examination is normal. On bimanual examination, her uterus is 10 weeks size and fetal heart rate is 150 beats per minute. Her TSH level is 13 and the free T4 level is 0.7, and her anti-thyroid peroxidase antibody level is high. And the next step, best step in the patient's care, is begin levothyroxine, repeat the serum TSH and the free T4 after 20 weeks of gestation, measure the serum thyroid stimulating immunoglobulins, perform ultrasonography of the maternal thyroid. The answer is A, begin levothyroxine. Although the patient is asymptomatic, she has laboratory evidence of overt hypothyroidism with an elevated TSH level and low free T4 level. She also had elevated anti-thyroid peroxidase antibody level, which indicate that the likely cause of her hypothyroidism is chronic autoimmune thyroiditis or Hashimoto's disease. The anti-thyroid peroxidase antibody also indicate an increased risk of her developing other autoimmune disease such as adrenal insufficiency or type 1 diabetes mellitus. Hypothyroidism in pregnancy has been associated with preeclampsia, gestational hypertension, abruptio placentae, preterm delivery, and neuropsychological deficits in the child. And thank you very much.